then let's start, and welcome to this first appointment during August for the seminars. Today we have a special guests, not one only, but three guests. We have Professor Andrew Demchuk from Calgary, Professor of Vascular Neurology. And we have two colleagues from Ukraine, Irina and Bogdana, who spent 20 days, if I remember correctly, in the University of Perugia at Santa Maria Hospital in the stroke unit with Valeria Caso and Maurizio Pasciaroni. We would like to have first them to share their experience, and then we will move on to Professor Demchuk's presentation. And please, Paolo, introduce again how the system works and how we are able to provide simultaneous translation. Thank you.
Доброго вечора, шановні колеги. Тоді я почну одразу українською.
Dear colleagues, I will start with Ukrainian. Before we start our meeting, we will have an opportunity to listen to the experience about visiting the Perugia University by Bogdana and Irina. If you want to choose an alternative language to hear, you may press the button below the screen, whether it is English, whether it is Ukrainian. You may see the globe picture below your screen, below your Zoom application, where you can switch English to Ukrainian and Ukrainian to English for better understanding of what we will speak today about. So let's stop spending our time. So please, Bogdana, you may start speaking.
Я англійською хочу кілька слів сказати.
I want to tell a few words in English.
Romania Pucella, I am very grateful for you and Valeria Caso, Professor Valeria Caso, for helping us in organizing this amazing journey, this amazing experience. It was a wonderful opportunity. Thank you so much for organizing this wonderful experience. I would like to make it in Ukrainian to make it more convenient, if you don't mind, because of the majority of the listeners. So let me start. Отож, шановні колеги, доброго дня.
Dear colleagues, good afternoon. I want to share. I want to share my experience about me and my colleagues visiting the wonderful, peaceful city of Italy, city Perugia, that is located in Italy. I want to thank Professor Yuri Flomin and Francesca Romana Pazzella for her organization, and Professor Valeria Caso. They helped me to organize this journey and our staying there and our adaptation especially. Here you can see the photos of this peaceful city. Here is the hospital, Santa Maria della Guardia, and the staff of the hospitals. Their professionalism level was amazing. They are true professionals, and they helped us to adaptate there. And a few words about the stroke care organization in the hospitals. And the hospital has a status of the stroke center where the thrombolysis and thromboextractions are provided. And the hospital is also cooperates with other hospitals which have stroke units with other alternative methods of the stroke care. Here you can see the angiograph on the photo. I hope you feel the atmosphere through this photo, which we also experience there. Speaking this stroke care and neurologic care, there are two two specific units in the hospital: the stroke unit, where there are 8 beds for stroke patients. There are 5 strokologists which provide stroke care every day, 24 hours. And there are two assistants of the doctors and a lot of other alternative staff. We were amazed with the premises of the hospitals and their design and their instrumentary. And especially I want to note that the electronic system of the patient control is also very well provided and organized. The doctors may provide prescriptions and consult their patients through the specific system in the computer. For me, it was exciting because we didn't see such system in Ukraine. Speaking about the technical equipment, it is wonderful that there are 3 CT machines. There is an emergency department which provides the urgent care for patients. There are also an MRI machine, which is also available 24 hours for instrumental diagnostics. It's also important to note that there is a department of general neurology in the hospital, where the hospitals with sclerosis, myasthenia, and other neurological diseases are held. Also, I want to share that thanks to Professor Valeria Casso, we had an opportunity to visit a hospital in Rome. It was a wonderful opportunity because, except for the fact that we were there only for a few hours, we visited the therapy department and we saw the patient that was hospitalized there, and she got a thrombolysis. She was taken from the stroke unit of other hospitals, and here you can see these hospitals. We were excited with the operativity and well organization of all the actions, and the thromb extraction was provided on the highest level, and everything was perfect, I must say. The staff was polite, they were open for cooperation, they knew English, and they understood everything that was provided during the operation. The organization for stroke care is quite a little bit different from the St. Maria Hospital. I'm sorry for having only a few photos of this, because it was hard to take photos of all premises of the hospital. Here is the stroke unit where there are 8 beds for the patients. There are 8 beds and 4 nurses for these patients. When the patients come from the more complicated condition to a more light condition, he is carried to another bed and another part of the department. Here you can see one more photo for this hospital. There is also a multidisciplinary team where there is a logopedist, a dietologist, and a psychologist. The logopedic doctor, he provides services 24 hours per day, and he provides different types of medical services. There is also a physical rehabilitation services in the hospitals, which is provided practically every day for the patients. There is also an intensive and extensive rehabilitation for the patients. The type of rehabilitation is chosen depending on the specific condition of the patients, or when they are taken coming from another hospitals from the country, and their specific anamnestic data. There also I visited a specific stroke room in the hospital. And in Perugia and Rome, there were also two stroke rooms where 2 days a week patients with stroke, 3 months after they were diagnosed with stroke, they may come to this room and be monitored with the doctor's help. And it's wonderful because the neurologist has possibility to monitor such patients and see their analyze their conditions. So that's all. Thank you for your attention. I hope my talk was useful for you, and I hope that we will have a wonderful time later, and Ukraine will win in this war.
Thank you very much. It was very nice to see friendly faces and familiar places with you, the Gemelli Hospital and Perugia.
Thank you.
And this is, I'm happy because this is an example of what the Task Force for Ukraine, the European Stroke Organization Task Force for Ukraine, was able to do during these months to help where there was a possibility to support. And of course, our doors, at least in Italy, are still open. And so if there is anyone that'd like to come or, there are projects that you would like to develop with our support, you're more than welcome. I would like now to give the floor to Professor Andrew Demchuk, Director of the Calgary Stroke Program. He's presenting today, I think, a very relevant topic for a neurologist, which is neuroimaging for neurologists. It could be the title of a book, Andrew. I think if you have not written it yet, please consider it, because I think it's extremely important for residents, and also for those that are already neurologists. It's always very important for us to be informed in this essential part of our work. So Andrew, thank you again for joining us. We really appreciate it, and the floor is yours.
Thank you very much. You can see my slides?
Yes, absolutely.
Wonderful. Okay, so I got asked to give a broad topic of, well, first off, Slava Ukraine, right? This is the most difficult time for all of you, and I'm so impressed and proud that you all just carry on your work. And I think that's what we all have to do. We carry on our work and do the best we can, be the best doctors we can for our patients, and hopefully things settle. So Slava Ukraine. I'm going to give this lecture in English. My Ukrainian я знаю трошки набагато українець. It's just much better. I teach this in English. So hopefully it's okay. You can follow along either in English or translation. Been asked to speak on neuroimaging for the neurologist. I'm going to obviously focus on stroke and TIA with this, and just give you sort of broad strokes of where I think neuroimaging has its most crucial role around key findings that influence management of stroke and TIA patients. So this is my responsibilities, conflicts, and disclosures. I'm involved in a number of different trial-related work. This is the outline for what I'm going to try to do here today. I'm going to start with talking about imaging and acute disabling stroke, and then move to minor stroke and stroke workup very briefly. I'll try to get through this quickly as we only have about 40 minutes or so. So I'll start by reminding all of you the type of images that you perform matter. We have been applying the same protocol in Calgary now for almost 10 years, which tells you something about how practical our protocol is, that really, I think, simplifies investigation of patients. And I would really encourage, and I'd love to answer any questions around this. This requires buy-in from your radiologists. This is really important. For intracerebral hemorrhage, I'm going to only show one slide, and that's this slide, which outlines the fact that in our center, we do a plain CT and a multi-phase CTA of the brain in all of our intracerebral hemorrhage patients. And we do that primarily to detect secondary causes of hemorrhage, which are very easily detectable now with CTA. The multi-phase component of CTA allows us a venogram on the second or third phase of the CTA. So we get venous structure information as well, which of course is quite relevant in hemorrhage and can be the underlying cause in some settings. About 13% of CTAs in one study detected a secondary cause of ICH. So the yield is not insignificant if you do the CTA. There's some other interesting things with CTA, including spot sign, that are in development, but don't really change practice, so I won't get into them today. On the ischemic stroke side, it really is about a plain CT, a CTA of the neck with a multi-phase CTA of the head. We never leave the emergency department without a CT-CTA in general, although we are going currently through a contrast shortage in Canada, given the supply chain issues in China. So we are limiting our use to some extent in lower risk patients, usually in the TI group, and I'll come back to that. We only do perfusion imaging in selected patients, and we'll also come back to that a little bit later. So this is our protocol, and I really want to emphasize the protocol matters. It's one thing to learn how to interpret these things, but you've got to have high quality images to begin with. And I do a lot of core lab work and clinical trials, and I see a lot of very dubious imaging acquisition out there where the attention to detail has not been provided by radiology to get good images to you, okay? So this is our standard of care. We published this review in Stroke a few years back. It has a very detailed description of our protocol, which hasn't really changed at all in all of those years. We do a 5 mm thick section non-contrast CT. We do 0.625 mm thin section non-contrast CT, and we generate MIP images of the thins, which allows us to see the clot size and length quite well. We then do a CTA of the neck, which is immediately followed by 3 phases in the head with movement of the gantry. And then we get maximum intensity projections in all 3 planes, coronal, axial, and sagittal planes, both head and neck and head. For major strokes, we never wait for a creatinine. A CT-CTA is done immediately while the patient is still on the table, and it's done stat. We never wait, okay? And the reason we never wait is neurons over nephrons. This is a publication. We did a meta-analysis where we really wanted to emphasize this concept of neurons over nephrons. 3% of patients had a rise in their creatinine that got a CTA, and only 0.07%, that's 3 out of 4,000 patients, ended up on dialysis after a CTA. So this is not a high-risk situation. In fact, case control studies would suggest it's of negligible risk. I also strongly encourage a CT over an MRI in TPA decision-making. MRI is slower for a variety of reasons. There's a quasi-randomized trial that showed at least a 12-minute slower door-to-needle time with MRI. And more importantly, close to half of patients that were allocated to MRI in this trial ended up getting a CT anyways, because of contraindications or the clinical condition of the patient being too difficult to perform the MRI. So let's just start with a CT and avoid all of this nonsense of trying to get someone in an MR machine acutely. It's just not practical. Now, if we talk about key neuroimaging findings in acute disabling stroke, we should start by thinking about the clot. So this is the so-called hyperdense MCA. This is actually an ICA-MCA sign. And we know from the Hermes collaboration of EVT trials that there is a strong benefit for thrombectomy if you have a hyperdense sign. It's very strong benefit, odds ratio 2.77. So you actually, if you see an obvious hyperdense sign, you could argue not even to bother with the CTA, just go ahead and send the patient immediately for EVT. And that's perfectly reasonable for an obvious hyperdense sign. We do thin section CT, and many centers do this now, which allows us to see the clot size and length much better than a regular thick axial cut. because the thick axial cut has volume averaging in the Sylvian fissure or the CSF space, basically. And so you want to have a thin section CT to see the proper extent and size of the hyperdense sign. We use the 0.0625 mm. Some centers use 1.25 mm or 2.5 mm. The 8 millimeter clot length matters. TPA rarely recanalizes arteries much past a centimeter in size. And in a randomized trial called Therapy of IVTPA versus IVTPA plus thrombectomy, patients that got IVTPA alone did just as well if the clots were less than 10 millimeters. But EVT was crucial for clots larger than 10 millimeters in that trial. Now, not only does the thin section CT give you clot information, the CT angiogram will tell you where the clot is. And of course, these are the classic locations, most of these being LVO, some of these MEVO locations of where you can see an occlusion very easily by CTA. Internal carotid artery occlusions benefit very remarkably for EVT. In fact, I would argue in Ukraine, we have to move to EVT much more swiftly if we can, especially in internal carotid artery occlusions. The benefit strongly outweighs control arm patients in this group. IVTPA is a limited therapy in internal carotid artery occlusion. For MCA M1 occlusions, there's also a benefit for EVT, but it's more modest as opposed to internal carotid artery occlusions. We now have benefit for proximal M2 and dominant M2 occlusions, and benefit in basilar artery occlusions from two very recent trials called the Attention trial and the Bayouch trial, both performed in China, with a number needed to treat of roughly 4 in those trials. If you look at the benefit of EVT, it's essentially all of the big clots right up to the proximal M2. Where we don't have evidence yet is in what we call the medium vessel occlusions, or MEVOs, which are distal M2, M3, PCA, and ACA in their clinical trials now just launching, testing smaller catheters to pull out those clots. There's someone's got their hand up. I just wonder if they're having trouble hearing me or something. Someone just comment there. There's a hand up. No?
No.
Yeah.
I think these are comments on there. There are questions that we are going to ask you later. So
Okay.
it's okay.
Okay.
We can hear you very well, and it's all going very smoothly and fine.
Perfect. Okay. So the second element of neuroimaging that's very important in stroke is core estimation, or what we call how much dead brain. And this is where we utilize Aspects, something we developed in Calgary that's gone global back in 2000, where we measure the regions of the brain where we see early ischemic change. We look at 7 structures at the ganglionic level and 3 structures at the supraganglionic level. And we like to see change on 2 consecutive cuts to call it. So if the M4 region is involved in consecutive cuts, then I take 1 point off for M4, et cetera, et cetera. For those of you that are inexperienced with Aspects, we have a free website we've been using for a number of years. We get lots of global interest in this website. It's called aspectsinstroke.com. Please go on there. Please quiz yourself on it. There's also collateral assessment tools on there as well. It's all free. We really just want to disseminate this knowledge and interpretation skill to whomever is interested. Mild hypoattenuation is essentially what we're looking for in this. This is a patient with a right hemisphere stroke that has very subtle early ischemic changes. You can see the gray-white on the left side of the brain, but on the right, it's all blurred out, but it's really pretty subtle. And a lot of doctors have a hard time distinguishing these regions of ischemia. This is an example of a patient with a ICA and M1 clot. You can see the hyperdense ICA and M1 sign there. And you can see a large region of the brain in the left hemisphere here with some early subtle change. The basic ganglia is darker, the caudate is darker, and many of the cortical structures are losing their distinction to white matter. So we'll take off points for all of those Aspects regions at the ganglionic level. Then we go higher up in the supraganglionic level and take off points for all of those structures as well. So this patient ends up with an aspect score of 1, which is a very poor scan, very extensive infarction. And there's the follow-up scan in the same patient. So you can see that really all that territory ended up dying in this particular patient. We don't have really good data on the cutoff for giving intravenous TPA, but I would argue, based on the work we did in the NINS trial, we went back and read all the scans in the NINS trial back in 2003, and we were blind to treatment assignment, and those patients with really bad aspects had big strokes regardless of therapy. So I personally don't give IVT TPA to patients with the aspect 0 to 2s, but above 2, we really don't have enough data to sort of say much. And even below, at 2 and below, the numbers of patients from the NINS trial are very small overall. The same thing can be said for EVT therapy. There are clinical trials going on right now in low aspects patients. There's one MR-based study that's been now presented and published in Japan for mid-range aspects 3 to 5 showing benefit. In Hermes, it was the aspect 0 to 2 group that did not seem to show any benefit to EVT. So the same cutoff for TPA I would use for EVT at this stage. These wipe out almost full MCA territory patients with these very low aspect scores. Beware of the subacute infarct where you see very dark areas, much darker than normal white matter. This is subacute infarcts, and we know at least from Get With the guidelines that patients with recent strokes in the past 2 weeks are probably at increased risk of bleeding with TPA, maybe as high as 16% in this fairly small series of patients where patients were treated who had a recent ischemic stroke within 14 days. Collateral imaging is another element. We like to do temporal collateral imaging, and I'll explain that in a moment. So what is collateral imaging? Essentially, it's backdoor flow, right? We are measuring the flow that fills in via the back door when the front door is closed. The M1 is occluded. And the backdoor flow is the leptomeningeal filling of vessels that you see on a MIP projection. That's a maximum intensity projection. A lot of people make the mistake with collateral evaluation. They just look at the source images and all they can see is dots out here. You need to do a maximum intensity projection of about 2 centimeters, and now you'll see all the vessels beautifully. And it's not a dot evaluation, it's a proper collateral evaluation. And those collaterals can fill in multiple different ways. These are a bunch of cartoon renditions we did in a review that we did, kind of illustrating how the flow can get through the back door when the front door is closed. We use multi-phase CTA to look at collateral. So we do neck, 1 run of head, move the gantry back down, do another run of head, move the gantry back down once more, do a 3rd run of the head. And each of those runs of the head are 8 seconds apart, 4 seconds to move the gantry and 4 seconds to image, essentially. And what that allows us to do is to see delayed collateral filling that you're going to miss if you only do a single phase CTA. And it's important because collaterals, even if they're delayed, the mere fact that they're filling in probably means the brain isn't dead yet. And so that is something we've learned well, that patients with excellent or good collaterals, where the collaterals fill in quickly with minimal delay by the 2nd or 3rd phase of the CTA, will still do very well and have long time windows. These are patients with very high aspect scores, very small cores, and very long periods of time before the brain dies. You can transport these patients 100 kilometers to a EVT center in Ukraine when they have a scan appearance like this. They have a very slow death of brain. On the flip side, if you do a 3-phase CTA and you see minimal or no vessel filling on any of the 3 phases of the CTA, these are 8 seconds apart again, this is a poor collateral situation. This is a patient with a low aspect score. These patients are infarcting very rapidly, and the time window for helping them is very short. I generally only treat young patients early in the window in this clinical situation because they're likely to suffer substantial infarcts despite what you do. CTP, when to do and when to use it. This is essentially a tool that has 2 major defined roles in my view right now, today. One of them is to rule out, to help you with mimics. and the other one is late window treatment, okay? CT perfusion maps are quite challenging to understand. I like to keep it simple and say, know your CBV map, know your CBF map, and know one of your time maps, okay? And the rest of it, try not to get too into the weeds with this. Fortunately, we do have technologies now. There's a number of companies that have automated softwares that allow us to detect what areas of brain may be dead or soon to die and what areas of brain that are at risk, the so-called penumbra and core imaging. There's lots of controversy around these automated softwares, and you do have to be careful with them, especially in the early time window where they're not as well established to identify appropriate patients for treatment. But they do seem to have a significant role, especially in the late window. Where I like perfusion, where you may not have heard about it so much, is when I'm wondering whether it's a stroke at all. Patient presents acutely, but there's just something clinically that's not right. I don't want to give a thrombolytic to this patient. I think they're a mimic, so I'll do a CTP. A majority of patients where you do a CTP and it's a mimic will have no CTP abnormality whatsoever. They have a non-altered perfusion CT, okay? That's the majority. Sometimes, though, you get some really interesting findings on perfusion. For example, sometimes the flow to the brain is faster. So normally in a stroke, there's a delayed filling. There's a delayed filling of collaterals and therefore a delayed perfusion in the brain. That's a sign of ischemia. Well, in mimics, the flow is actually increased. The Tmax is actually faster. The CBF is increased and the CBV is increased. So those are classic scenarios for a mimic. And we see this quite commonly in a seizure. When a seizure is mimicking a stroke, where you've missed the seizure history or observing the seizure, but there's actually increased flow on the CBF and CBV and faster flow on the TTP or Tmax. The other findings that are interesting is sometimes you get bilateral defects in vascular territories or defects that don't follow a vascular territory. This is an example of a migraine here, where you've got some occipital lobe increased Tmax and reduced blood flow, but this doesn't really follow a vascular territory. That's sort of a typical migraine presentation. Sometimes you see a holohemispheric perfusion lesion. That's not within a vascular territory either. Or in this case of PRESS, you get multifocal areas of perfusion abnormality. So it really allows us to understand the mimics. Where CTP has its proof is in the late time window. And of course, we have 2 randomized trials of EVT treatment using CTP to detect small cores of ischemia that benefit from treatment even up to 24 hours for EVT if a large vessel occlusion is present. So moving over to mild stroke now for a few minutes, this is where a CTA is an urgency and not an emergency. So perform it within hours. Wait for the creatinine. You have time to wait. I would not do a CTA on someone with quite a poor creatinine if they're a minor stroke, but I would do a CTA at a major stroke regardless of their creatinine. The types of patients we prefer to do CTAs on are patients with speech or motor symptoms, so high ABCD scores, longer duration spells, and spells that occurred recently. Why do we care about recent spells? Because recent spells have not survived their highest risks yet. If they just had their minor stroke or their high-risk TIA in the last 3 hours, their greatest risk is going to be overnight in the next few days. So that's the type of patients you want to do CTA on. If they don't present to you in your clinic until 2 weeks after their TIA, they're already have survived their highest risk. That's not someone we need to be doing a CTA on. That's a precious resource that we have to spare for our radiologists when we can. So really in minor stroke TIA, it's all about who is vulnerable. And this is the Niagara Falls concept, where you've got a patient and you really don't know what you're dealing with. You just see the tip of the iceberg. All they've got is a minimal deficit and you don't know what they face in front of them. In the CATCH study that we published in Stroke a number of years ago, we prospectively enrolled 500 patients in Calgary performing a CTA within 6 hours of onset of the TI minor stroke. And 1 in 3 of the patients had major plumbing issues somewhere on the CTA, either right from the aorta all the way up extracranially and intracranially. Anywhere in that circulation, there was a problem somewhere in 1 in 3 of these high-risk TI minor stroke patients. And so it really is about detecting that early risk, and that is most important in patients with large artery athero. So that's really the big gain. This is a publication in International Journal of Stroke, another review we did. This is actually a very worthwhile going through this. We have a lot of illustrative examples of the various pathology you can see in a CTA and minor stroke and high-risk TIA patients. These are our indications for emergent urgent CTA. They sort of match what I've already explained to you. I don't do CTAs in the dizzy, woozy, blurry patients, and I don't know how often they come to the emergency room in Ukraine, but they certainly come to the emergency room in Canada. And they are not high-risk patients, the dizzy, woozy, blurry patients, the vertigo and isolation patients. We try to avoid CTAs when we can. The numb, tingly patients that have resolved, we also don't perform CTA on. So if you focus on the high-risk TIs, the motor speech TIs, the persistent deficits that recently occurred, if the CTA is negative, we can send those patients home and do. We like to save our beds in Canada. We can't fill our beds with TIA patients. If their CTA is negative, they go home and they're brought back to the clinic with other investigations that might include an MRI or cardiac tests. But if the CTA is positive, we admit them. And the most important thing we look for is obviously extracranial carotid disease, because we need to deal with that carotid with urgent revascularization. We also need to rule out a thrombus, because we know the risk is higher to revascularize a patient if there's a large thrombus in the carotid, and CTA is very nice at looking at a large thrombus. The benefit of early revascularization in a symptomatic carotid stenosis is only an NNT of 3 to 7 if you operate within 2 weeks of the event. A CTA is your fastest way to detect carotid stenosis in a timely manner to get carotid vascularization done within 2 weeks. The other important finding is that of an intracranial occlusion. The chances of stroke progression or recurrence are increased 10-fold if you have an intracranial occlusion in a mild stroke. And so we are focusing on these intracranial occlusion patients in the Tempo 2 trial, where we're currently randomizing them to TNK versus antiplatelets. And the study is progressing nicely. It's a 7-country trial right now, 8-country trial right now with 742 patients randomized thus far. So hopefully have an answer for the world in about 2 years. Stroke etiology determination is the last part of neuroimaging I'm just going to quickly comment on. As a stroke neurologist, I can't stand when my patient recurs. It probably means that I missed the etiology. I didn't get it right. The risk of stroke recurrence is about 5% 1 year and about 15% at 8 years overall. It is falling overall because we're getting better at identifying the etiology correctly and starting the right therapy. There are a number of important ischemic stroke etiologies to sort through, and they do require a variety of tools, some of them being also cardiac. I'll focus on the neuroimaging side, or the brain related tools. This is the suite of tests that we perform in what I call a stepwise timing. We do the CTA in the emergency room with the CBC and some basic blood work. On day 2, we do the MRI, the echo, the Holter, some of the more fasting blood work. Day 3 to 5, only in patients where we haven't found a cause, we might do additional tests that could include a bubble study. And then beyond day 3 to 5, we get into some of the rarely ordered tests in patients where we can't find a cause, especially if they're young, that might include a TE, a cardiac MRI, or thrombophilia screening. And then, of course, in some cases, we have to perform prolonged ECG monitoring as well. I'll focus for a moment on CTA. Obviously, large artery atho is what we're looking for on the CTA. We can pick that up right away and emerge, and we look right from the aorta all the way up to the intracranial vessels. I often see radiologists underreport aortic disease, underreport great vessel origin disease, and underreport siphon disease. In fact, I often have to look back myself and review those areas because the radiologists have completely missed interpreting a severe stenosis or major plaque or protruding lesions or ulcerations in one of those locations. So very important to develop your skills in CTA. All of our stroke fellows in Calgary get very well trained on CTA. It is a bread and butter tool for the stroke neurologist. The other type of etiology is arteriopathies, looking for a variety of different arteriopathic conditions. The one that has really come up to light recently has carotid artery webs. This is a significant cause of stroke in young cryptogenic stroke patients. They're an outpouching at the bifurcation of the carotid. It causes a slowing of flow beyond the outpouching that leads to clot formation. You can see this is an angiogram beyond the web where the blood is stagnant. The flow is completely stagnant, and thrombus forms in it, and they tend to recur, and they can recur very badly. And there's now data, not randomized data yet, but data suggesting that we can completely prevent recurrent stroke by revascularizing or removing the web. And so we're increasingly doing that now. It'd be nice to have a randomized clinical trial. I'm not sure that'll ever be done, but c'est la vie at this point. This is what we know so far. Medical therapy seems to fail these patients. They still seem to form clot because there's a flow problem overall. On day 2, we use a fast MRI stroke protocol. Because we do a CTA in the emergency room, we don't have to do an MRA of the head and neck the next day. It would be duplicative. So we just do a fast MRI, which includes diffusion, flare, and some sort of hemorrhage sequence, either a GRE or SWI. So 3 sequences, 15 minutes in the scanner, no gadolinium required. Radiologists love it because they can put more patients through, and we get the key stroke information we want. If there's no diffusion abnormality, I'm beginning to stop dual antiplatelet therapy in minor stroke patients because their benefit with clopidogrel does not seem to be present in the absence of an infarct. So I will generally back off on dual antiplatelet therapy if there is no infarct seen on the MRI. The fast MRI protocol tells us the pattern of infarction. The pattern that is most dubious is the one of multiple infarcts. The large artery athero pattern tends to be in one vascular territory where you see multiple diffusion lesions. We know that the dual antiplatelet therapy probably has its greatest benefit in such patients with multiple acute infarcts. There's a larger benefit seen, at least in one trial. We have this data now favoring dual antiplatelet therapy, and that makes sense because these are actively embolizing patients that are having multiple little infarcts in one vascular territory. Another pattern that's picked up beautifully by MRI that we're really getting used to now, I see about 2 of these a week, is the cancer-associated thrombosis pattern of multi-territory small scattered emboli, involving usually both carotid and posterior circulation territories. Small scattered emboli. If a patient has multi-territory strokes and has a high D-dimer, their risk of stroke occurrence at 1 month is 40%. Yes, 40% at 1 month. This is the highest risk stroke etiology. You can't miss this, or your patients will keep stroking. You got to pick this up, and the multi-territory infarct pattern MRI is how you do that. The management of this is really low molecular heparin or a DOAC, and it really depends on the type of cancer that's underlying this condition. GI cancers especially don't seem to do well with DOACs. There's lots of bleeding. So low molecular heparin is often used in that setting. We need clinical trials in this scenario. We haven't had specific trials, although we've had lots of trials with these agents in the venous thrombosis of cancer. I'll briefly mention TCD bubble studies because I would consider that a neuroimaging tool. The TCD bubble study is the gold standard for detecting right to left shunt. So if you've got a young patient and you're wondering about a PFO, the TCD bubble study is the way to go. We have shifted completely to bubble studies. We miss way too many right to left shunts with transthoracic echo and even transesophageal echo. This is a tool that should be in the hands of neurologists and neurosonologists. So please do the TCD bubble studies. We have clear benefit for PFO closure overall. So the bottom line here is you've got tools. If you're concluding the etiology is cryptogenic, you may not have explored far enough or in depth enough to find the true cause. You have to look under every rock and persist until you succeed. So in summary, looks like I've left about 10 minutes for questions, which is perfect. For major ischemic stroke, remember the 3 C's when you're performing a non-contra CT and multi-phase CTA: clot, core, and collateral. Clot is the location of the occlusion and size and length. Core is the dead brain, and collaterals are the filling, the backdoor flow that's so essential to keep brain alive. For IVTPA, excellent therapy if clots are short. For EVT, it's a perfect companion to IVTPA since it works much, much better in large clots. And in most clinical settings, it now has proof for proximal M2 occlusions and basilar occlusion. Low aspects, no collateral patients are going to have large strokes regardless of treatment. And if the aspects is really low, they probably won't benefit. We're still learning, and there are still trials ongoing in this space, however, with EVT. CTP can rule out mimics. I like it particularly in this setting. And its best use, however, is for EVT decisions in the later time window, up to 24 hours with an LVO. Minor stroke and TIA. CTA determines hospital admission in Calgary, which is, I think, an approach that many socialized health systems could consider. Detects ICA stenosis fast for early revascularization, and predicts early neurological deterioration by the detection of intracranial occlusion. You do not want to send a patient home with an intracranial occlusion because they're going to bounce back the next day or day after with a hemiplegia, and the family is going to be quite upset. So in our view, knowing that, determining that information in the emergency room is helpful because you admit the patient and you've got them under your watch, at least, as you go forward with clinical trials ongoing to see if reperfusion therapies benefit this group. And then lastly, for stroke workup for etiology, the CTA in the emergency room is important for the angiopathy and large artery athero etiologies. Fast MRI is great for the infarct pattern or even the presence of an infarct, which may help you decide whether you want to continue DAP therapy. And the TCD bubble study is the best. It is the gold standard test for right to left shunt detection for PFO and consideration of closure in younger patients. So this is a quick run through of a lot of stuff. I tried to be quite clinical and pragmatic with it. I'm more than happy to come back and to get into the weeds more on some of these things in a future lecture. It's been a pleasure. For me, this is in many ways very difficult I can imagine how difficult it is for all of you to focus on medicine and stroke and what you're facing. But I think it's so important that we continue to provide the care that we can. So, Slava Ukraine, thank you for your attention. Dobry den. Open for questions.
Thank you so much for this really very nice presentation. And I really think you should write a book. It's so important what you presented to us, and I think it's really crucial for neurologists. We have a lot of questions from Yuri asking. So I'm reading in English. As the first one, I'm really curious to hear your opinion concerning the possibility to use aspects in neuroimaging with MRI. Yuri is asking if whether or not aspect is applicable to WI imaging, despite the fact that it was developed for CT, and is also asking if aspect is valid in posterior circulation strokes.
Great. No, those are excellent questions. I didn't get into those, but those are important issues. So yes, MRI has been applied. Aspects has been applied to MRI. In general, Yuri, if you use MRI, you score about 1 point lower on average because you can see those little subtle infarcts sometimes, those little hits in one territory that you would never see on a CT. So generally speaking, the aspects, when you compare the same patient who has an MRI and a CT and you do aspects for both, the diffusion weighted aspects tends to score about on average 1 point lower. So this was relevant in the recent Japanese EVT trial in low aspects patients. You may have read that trial recently. And so when you're looking at that trial, it was MR-based Japanese trial. So the cutoff they used would equate to about 1 point lower than what most of us centers that use CT would use. So it was a 3 to 5 trial, but it was really probably a 4 to 6 trial on CT. So that's one way to think about it. One question that's often come up is how much change within a territory in diffusion is enough to call a point off? And I've debated this with Jeff Saver. We've talked a lot about it as a community, and people say, well, I'd say, maybe about 20% of that region, but we really don't have a hard and fast rule for that, right, overall. The bottom line is you certainly can use it. For the posterior circulation, we have developed something called PC Aspects. We published it a number of years ago. It's sort of a similar, it looks at the thalamus, looks at the pons, the midbrain, the cerebellum, and it has been applied to the basilar artery occlusion trials. It doesn't seem to define a group that doesn't benefit versus benefit. Like all the PC Aspects patients tend to benefit from basilar artery occlusion EVT overall. So it hasn't been discriminating yet, but I haven't seen enough data on the lower range to really know for sure about this. And so I think that does need to be studied a bit more. Certainly when most of the brainstem is infarcted, that's when it may not matter, right? Whether you do EVT or not. We really need more information on these basilar occlusion patients where the pons and midbrain is very dark, because these patients typically won't do well. So the posterior circulation story needs to evolve a bit more, I think, with Aspects, but there is a tool called PC Aspects.
Yes, I do agree with you with what you just said concerning the aspect in the posterior circulation. This is something which is, we should look into, I think, because fortunately posterior circulation stroke are rarer, but nevertheless, when you are there and there is a problem with extended windows, it's always difficult to decide sometimes. So it's not easy. Yuri is wondering if you see cases when aspect is reduced on the repeat CT compared with the initial CT. For example, you have an 8 versus 6, and how can you explain that?
Yeah, well, so that is called Aspects decay, and it is essentially Aspect decay equals infarct growth is the way to think about it, right? So we have many examples. We have a primary stroke center in Red Deer, Alberta, which is an hour and a half north of Calgary. It's a good center, big population, about 200,000 people live in the area. We'll often scan a patient very early in Red Deer. Aspects will be 8 or 9. We'll rush the patient down to Calgary for EVT therapy within 90 minutes, and Aspects is 5 by the time they arrive. That is infarct growth. That's expansion of the infarct into the penumbra. Usually that's patients, Yuri, with poor collaterals that typically will grow fast, but you will often see an 8 turn to a 5. The trick in imaging, though, is the collaterals. So you can almost predict, Yuri, when you're going to go from 8 to 5 in Red Deer to Calgary by those collaterals. If the collaterals are poor, you can bet that that's what's going to happen. If the collaterals are good, that patient might stay an 8 on arrival, right? They may not decay at all with really good collateral. So that's where the multi-phase CTA is golden. Beautiful tool, super easy. You just have to move the gantry. Doesn't even take any more contrast. And you can see that that patient has excellent filling and probably won't decay much by the time they get to us.
I see. Well, then
excuse me. Thank you very much, Andrew. But what I meant was just the opposite. When you repeat CT imaging 1 day after the treatment, acute treatment, and you see higher number on day 1 than on the initial imaging.
So 6 goes to 8.
Yeah, 6 goes to 8. Yeah.
Okay. Yeah. So I guess the first question is, did you get the 6 right? I mean, were the changes that obvious? Patients very early in the window, on occasion, you can rescue brain that looks like it might have subtle changes, but that's pretty rare, to be honest. It's pretty rare. I would actually wonder what's happening with the 6. Sometimes you can get patients where you get swelling without hypodensity, and swelling, some people take aspect scores off for swelling. Swelling can be reversible. So I would love, Yuri, for you, we should have a session sometimes where people bring these, and maybe that's a follow-up, Francesca. We could do a fun session in a future meeting where people bring their cases and some of their imaging like that, and we look at it together and try to make sense of it all. I always find these cases are a puzzle, right? And it's just a matter of figuring out how the puzzle comes together, and we can usually come up with a really reasonable explanation for when that happens. But what you're describing is actually quite rare.
Right. We have other questions from Yuri. Is in CTP, what imaging do you prefer to determine what imaging do you prefer in order to determine the volume of the core, CBF or CBV?
Yeah. So right now we're not doing any CTPs in all Yuri because we have a contrast shortage in Canada, big time. Big, huge contrast shortage. So really? We have actually put a moratorium on CTPs. We get all of our contrast from China and from 1G manufacturing lab, and they had major shutdown last spring. So we're still catching up. So we don't do any CTPs at the moment. But when we had done CTPs in the past, there's a variety of ways to do this. Bijoy Menon has published a number of very nice papers on this. But essentially, you have to be very careful. The RAPID software generally has used a relative CBF less than 30% as the measurement for core. This was based on thrombolysis studies. When we started doing thrombectomy, we were realizing that many of those regions where you use a CBF less than 30% actually didn't die by prompt reperfusion by thrombectomy. And Bijoy has written a very nice paper called The Golden Hour of Stroke, where if you're super early in the window, you have to use an RCBF less than 15%, not 30, not 20, but 15% to detect what is actually dead, despite EVT. So what's the problem is our thresholds are different depending on our therapy and where we are in the window. The 30% only works for TPA and probably works later in the window. 15% is the better threshold really early if you're going to thrombectomy. So move and target.
Right. And Yuri, which probably needs a session just for himself, considering all the questions, but thank you, Yuri, because it's a very interesting question. He's asking if what are the reasons for doing CTA in all patients with acute stroke, regardless of its severity?
As I've pointed out, so everybody with a stroke, so minor stroke and major stroke, right, deserves a CTA in my view, and that is to detect not only the occlusion for acute therapy, but also to evaluate for etiology of stroke and for early prevention. Right? So it's a multifold. If there's one thing I've learned, the sooner that I check the plumbing, the better. There's lots of patients with serious plumbing issues. If you don't check the plumbing, you're going to regret that you didn't check it in some of your patients because they're going to get worse and you're going to wonder why they got worse. You should have checked it. And that's something we've learned over the years. We're plumbers. Plumbers check the plumbing. You look at the plumbers now have really fancy infrared cameras they use. When you've got a leak in your house or a blockage in your house, they're doing it all the time. But stroke neurologists aren't checking the plumbing. It's crazy. We need to check the plumbing.
Yeah, I couldn't agree more. Yeah, I feel like a plumber too sometimes. Well, unfortunately, at least in my country, plumbers earn more money than stroke neurologists. I don't know about Canada, but here it's like that. But yes, we are like the plumber. So there is another question, is always from Yuri. He has other two, and then there are other two questions from another participant in Ukrainian, so it will be Pablo to read it. The question is, if you do not see any acute lesion or initial imaging, do you repeat imaging? If so, when and which modality, CT or MRI?
So I presume
Yuri, then after Andrew answers, I have a personal comment on this question.
Right. I presume you mean parenchymal changes. So I'll assume that the plumbing is normal, but you're looking for a stroke and you don't see it on the initial imaging. So that's where our philosophy has been very consistent. We do a CT at emerge, for all the acute decision-making and the plumbing. And then we do the fast MRI on day 2. Okay, not in every single stroke patient. We don't do a fast MRI on everybody. If there's an obvious infarct on the CT, we don't bother. But when we don't see much, we love the MRI, and it's only a 3-sequence MRI. It's only the diffusion, a GRE SWI, and a flare. It's 15 minutes long. That's it.
Yeah.
You don't need to do an MRA again because you've already got the CTA and emerge. And what that shows is your infarct pattern. It'll see the stroke. There's, we don't bother with a 24-hour CT if we're doing the MRI. It's one or the other. We will sometimes do a 24-hour CT if we're not doing an MRI, if we've given thrombolytics or something. But generally, it's a baseline CT and a 24 to 48-hour MRI, and that's it.
Yeah, that's what we almost do in my country as well. I mean, we don't. And the other thing I always say, that this was my personal comment, because sometimes I have residents really pushing and saying, "Can we do? There is no imaging, but the clinical, there is clinical significant. We should do the MRI now." And of course, there are hundreds of other MRIs that are more urgent. And what I usually say is that stroke is a clinical diagnosis. So we start from the clinic and then we go, let's not be anxious and let's wait for 24 hours, 48 hours. And the MRI will tell us that's what it is usually. And, but yes, this is an interesting topic.
Yeah, the MRI, the infarct pattern isn't an emergency. It's important for radiology and workup. But you do have a day or two to sort that out, right, Francesca? And that's why we're quite happy with 24, 48 hours, whatever.
Yeah. Well, once you have decided what to do in the acute setting, whether you're treating, what you're doing, I mean, once you have ruled out, what is your therapy strategy? What I think is, once you have decided that, then the rest, to be precise and see where this lacune is, how many millimeters, and it can wait. Sometimes it can wait.
It's pretty rare. I mean, I order an acute MRI. Maybe we order one a month, where there's some weird situation where you're not sure it's a mimic. You've done the CTP or whatever, and you just once a month or so we need an urgent MRI, but it's pretty rare.
Yeah, it's not that common. I mean, and the radiologist, the neuroradiologists, if you start asking too many acute MRIs, they'll start thinking you're not good at your job. But young residents, I mean, I encourage them to express all their doubts and say whatever. Sometimes we have to run after them and stop them by asking like 3 acute MRIs in one day. But this is just because they want to know. That's the answer. Yeah, but we want to know, but they can wait for a couple of days. But this is, yes, I agree with you. This is my same experience. And last question from Yuri is there a place for tissue-based selection beyond 24 hours? So we're talking about the next future after this future.
Absolutely, Yuri. We need a trial. We need a before the dawn trial or something, or I don't know what we would call it, but there is absolutely a need for a trial beyond 24 hours because we do see really slow strokes sometimes. It's a pretty rare group, but 5 to 10, I would say probably 5% of LVOs, maybe in that range, have this incredibly slow stroke where the basal ganglia is dying over many days. They usually have intracranial disease, by the way. They're usually ICAD LVOs, very unusual presentations. So you see it more in Asia. And so I think there will be a place for a latest, we'll call it a latest window trial someday. I don't know if one started yet, but I wouldn't be surprised if it's in planning. The curves diverge, out to 24 hours in dawn and diffuse. When you look at the Aurora analysis, it's very clear that we should be looking beyond 24 hours in some patients. We just need to figure out how to select them well and do a trial.
Yeah. And also there are treatments that may, somehow support the brain and the plumbing. And then if there is another event, you might decide to treat, and then it depends on what and how you're treating. I think the endovascular treatment is actually the future. That's it. Now we have other questions, but Pavlo is going to ask them.
Yeah, Also, thank you for great talk. I wanted to come back to CT and MRI before I read Ukrainian questions, and I have questions for me, and also Dmitry Lebedev had the same question. So when you told that MRI is very rare, but what about wake-up stroke or diagnosis of TIA? So if you perform CT for TIA patients, or better to do MRI for that for this patient?
Now, the wake up stroke population is a very reasonable argument, given that the wake up trial is the only sort of definitive trial in this space right now, and it's unfortunately the TWIST trial was a neutral trial with TNK that trended. There's lots of trending data for CT evaluation in late window, but none of it is, I would say, definitive. While the wake up trial was the one true definitive trial, and it was MR based. So I know places like Singapore, for example, will do acute MRI for wake up strokes, and I have no objection to that concept. It's just completely impractical for me in Canada to do that. So we do a CTP based approach in this window. It turns out, Pablo, that the flare lesion that you see on MR equates to severe hypoattenuation on CT. So it's a pretty dark change on the CT. So we have a pretty good idea of when brain is dead, and we shouldn't be treating. But I have no issue if you want to do an MRI in the late window. I mean, if you have that capability acutely, then that's no problem to me. For TIA, again, for TIA, MRI is nice, but it's a nice to have, I would say, and it takes a lot of resources. That's a lot of MRIs. There's lots of these patients. We have just found CTA far more practical, and has definitely been the Canadian standard for evaluation of high-risk TIAs. The MRI we do the MRI, Pablo, in the clinic, a fast MRI between day 2 and day 7.
Okay.
So we send a patient home with if the CTA is normal, we admit if they're abnormal, and then we bring them back to something called the TI Rapid Assessment Clinic the next day. We order the cardiac test, and in some patients we order a fast MRI for the MR. We don't consider the MR critical for the emergency department evaluation of TI, and it's just impractical for us.
Yeah, maybe with TIA also will agree, because the main thing that it's more complicated to do MR angio with contrast than to do CTA. CTA will be more faster in that case, and the main question if patient had a stenosis in ICA or not in most cases, for TIA. So
the other thing I would say about MRA versus CTA is I think CTA is far superior to MRI personally. Having looked at both, I think you see clots better on CTA. I think you see webs better on CTA. I think you can see stenosis and be sure about it better on CTA. You get a lot of flow artifacts and flow voids on MR that make it tricky sometimes. The arch is tricky on MR for being still. I just like CTA much more for plumbing evaluation than MRA, but that's my bias.
Yeah. Okay, and according to Ukrainian questions, what we have, so it's from radiologist. So first question, do you use more doses of contrast when you do visualization for collaterals flow, or no?
One dose of contrast, you start, so basically you trigger off the arch. It's your standard dose of contrast, you trigger off the arch, you do the neck and the head, the gantry moves back down 4 seconds later. Okay, it takes 4 seconds to move the gantry back down, and then you image for 4 more seconds. So it's basically 8 seconds. You get the second phase, move the gantry back down, third phase. It's all in the same bolus of contrast. So that's a really important beauty of multi-phase CTA. And that's actually better than CTP because you need 2 doses of contrast for a CTA and CTP. And this is another way to save X-ray contrast if there's a shortage. This is something that we have, have really adopted, especially with our shortage at the moment.
Yeah, totally agree. And according to Ukrainian guidelines, we use them mostly also from Canada. Right now, we also need to use CTP only for patients for whom we think it will be patients for thrombectomy. But for everyone else, it will be CT plus CTA. It's important and all patients should have it. And one more question, it's about MRI of the heart. So when you will perform this to your patients?
Yes. So, yeah, this is part of my step. You saw my one slide I made where, and please look at that slide carefully because I've spent a lot of time thinking about this. It's very important to stage your investigations for etiology because you can spend a lot of money and unnecessarily, right? I mean, you know, sometimes the CTA is good enough because it's a dissection or it's a cryostenosis, right? Why bother with all this other stuff? But sometimes you get through your stages and you still don't have a cause. That's where the cardiac MRI comes in, especially in a patient with a wall motion abnormality. That's the real clue that you should do a cardiac MRI, especially a wall motion abnormality, especially in the apex. You will pick up cardiac thrombi with a cardiac MRI that no other modality will pick up. So I like cardiac MRIs, especially in patients with wall motion abnormalities, especially if they're apical or anterior, if their LV function is down a bit. But also you do need to consider it in a young ESA stroke where you've exhausted all of your other causes. You look for discompaction syndrome and some of those weird things that can sometimes be a cause of stroke in young people. Yeah. But it's like a stage 5 investigation on day 7. Yeah. Where I've exhausted my workup and I only order about, I probably order 10 cardiac MRIs a year.
Wow. So like, yeah, it's because it's very important to do this, but it's so rare to MRI for heart. So
great yield for LV dysfunction and wall motion abnormalities. That's where the yield is. It's great at picking apical clots. I have seen lots of young people where we've missed apical clots on TE and they keep stroking until the doc does a cardiac MRI.
Yeah, so we have one patient like this, maybe 2 weeks ago or something like that. So I totally agree. We do the same thing on day 7. I think it was MRI for heart, but not before because everything like as you told. So I think we are finished with the questions. So maybe like a couple of words before we are finished from Francesca and Andrew.
Yes, well, Andrew, I'm really thankful for this very interesting lecture. I'm amazed about these lectures. Again, today we reached about 74 people at some point, which is extremely good results. As you know, this initiative is going forward. So I hope that you can join us again in the future and we can continue on discussing with you the neuroimaging for neurologists also from this organizational and let's say economical point of view that you have today talked about, which is something that usually we don't say, and we don't live in a world of infinite resources, but resources are limited by definition and unfortunately by reality. So I really enjoyed your presentation, and I hope and I'm sure that all the other colleagues have enjoyed it as well. So are you going to be with us in the for the next season of meetings?
Are you asking me? I'm happy to help any way I can.
Great. Yes, so you will be. Consider yourself already on board.
Happy to help. And like I said, sometimes you want to go deep into some of these discussions, right, with case examples. So that's the best way to learn on these.
Yeah,
right.
I think we will ask you that. Maybe we can. We have the questions that today Yuri has listed, which are I think very important. So maybe next time we will ask you to bring some cases of neuroimaging for neurologists. We can discuss around and see also the different approaches. But I think that we have very similar approaches, at least from what you said and my everyday life. So it's really very good.
Actually, Francesca, we've had a couple of excellent grand rounds discussing cases. Andrew and Dirk Krieger were the moderators, and our physicians, Ukrainian physicians, presented the case. You remember last year, Andrew, and the one before. So, and I sincerely hope that we'll manage to have it once again, or even not only once, because it's really I couldn't agree more with Andrew. It's a amazing way of learning and having feedback from experts and world-class specialists.
Yes.
Yeah, Stroke is a puzzle.
Yeah.
And usually all the pieces are staring you in the face. It's a matter of interlocking the puzzle, right? And kind of looking at it. And it's a very tricky disease, but when you've been at it for 25 years, like many of us, the puzzle starts to make sense most of the time, although we're humbled still.
Yeah.
Yeah, we have something like this. So maybe 1 month ago, so we have experience how to do this grand round with clinical case. So I think it's really can be done in the future, and it will be great for all of Ukrainian audience. So I will finish with some of words in Ukrainian. Okay. So, отже, шановні колеги, я сподіваюся, що
Dear colleagues, I hope that you got a lot of new information about neurovisualization for neurologists, and you got something new that is different from our canonic methods of diagnostics, considering neuroimaging. And now we will end. So I want to remind you that the next week on Thursday, we will have one more lecture that we'll be speaking about with the professor of the leading clinics of the Europe, and it will be the end of our summer season of lectures. So speaking about the question how we can get the recording of the lecture, you may visit the study platform of the European Stroke Organization, where you can see the lecture online and download it, where they will be available both on Ukrainian and English in both translations, and so you may download them on this platform. And on our last lecture, the next week, we will give you access to all the materials for downloading. So thank you. Thank you, Andrew.
To moderate this great talk and this session. So we wish you a good night and good day for Andrew, and good evening for all Ukrainian colleagues.
I'm going to sleep. Bye. Have a nice day or a good night.
До побачення.
Bye.
Героям слава, до побачення.